Okay. And we have hi everybody, I want to welcome you. You all come in muted, so remember that when you want to ask a question. And I told Joy and others that I don't have a particular agenda in mind, because I thought we should just chat about what we're up to. And we have with us today, and we really thank you for joining us, Joy Borkholder. I hope I'm pronouncing that correctly. Who is the new healthcare reporter with the Herald. And I've seen a couple of her articles that were pretty interesting. And I told her I would ask her to kind of start out by telling us about herself and whatever she thinks will be relevant to us in this area. So I'll turn it over to you, Joy.
Well, thanks for having me. I'm really excited to join and meet folks, particularly hear about the work that you've been doing on your committee. I will start by saying that I got pretty sick, I think, with RSV, and I don't know how much I'm going to be able to really talk today. So you all might need to do a little more of the talking, and I chime in.
Okay.
Short phrases. Excuse me.
Well, do the best you can.
Yeah, it just hangs on. I have a 7-year-old, so he's a little germ pile. So yeah, I just started at the Herald on the 10th. So about a month ago. I feel like I've lost about a week from being sick. And I think too, Tress, I looked at your email and you asked what I was interested in reporting on and talking about that, but I certainly have my own interests. But as I think you might know, this is a position funded by the community. It's called the Health Reporting Initiative. A big chunk of money came from Primera Blue Cross, but it's also meant to be community driven. And so for me to have a chance to listen to people like you in the county and hear what it is that you care about, what it is that you're wanting to see more coverage of or more deep dives into, that's really important to me and to the work that we're doing. And I think, some of that work happened before I arrived during the year with Brenda Mann Harrison, who is who helps some of these community funded positions. And some of those topics that came up were behavioral health, including, both mental health treatment and substance abuse, health equity, largely like kind of writ large health equity in the county, and rural health care. Those aren't the only things, but those kind of emerged as top 3. And I get a lot of leeway in what I'm covering in terms of I don't have to stick to breaking news and cover something every day, although of course I do when it's on my beat, when it's Regents and Optum at a contract impasse, or the RSV and flu and COVID overwhelming our emergency rooms. And I also get to think about big picture social determinants of health, which it sounds like you all are probably thinking about too. What is it about our environment and our economics and people's neighborhoods and education that leads to better or worse health outcomes? That's really exciting to me. So I'm a career changer, and I don't want to bore you with all of my background. I do have an MSW, so I have definitely some interest on the behavioral health side. And I spent some time working on state policy in Oregon, a little bit in Washington, and thinking about lots of different things like charity care, things to do with access, prices, what does consolidation in healthcare mean for people? And my mom's a retired nurse. Excuse me. And I think, I come to journalism, like I said, I'm a career changer, kind of from a research and data side. I love to dig into data sets. So whenever you've come across things that you find interesting or you wish somebody might explore, I'm happy to do that. But I come to journalism because I believe in doing work that has impact and telling stories and marrying data and research with narrative to really expose what's happening and have a better informed residents and better informed citizens. So that's my short ish version while I still have a voice. Excuse me.
I'm sorry you're still recovering. Hopefully you will be recovered soon, because it doesn't sound like a fun thing to have.
Yeah.
Let me start out just a little bit, and then I'll let everybody that's on the phone say kind of chime in with their piece of it. We have the league has had this league, Snohomish, which is one of the larger leagues in the state, mostly because King County has is broken up into several different leagues. So that makes us seem pretty large. I would say that the healthcare committee struggled for a while, and then in last fall I offered to take it back. Mostly, it sounds really bad, I was on the board and I figured they needed somebody, and I took it back thinking, well, this will be kind of low key, and I won't, I can just educate myself, because I moved to Washington State from California at the very beginning of the lockdown, so I really hadn't had a lot of exposure to people. Well, so we started out talking about healthcare equity during the pandemic, and then came Dobbs. And we also, that kind of, for me, women's rights are huge for me. And so that was kind of a defining moment for me, as well as last year, there was a legislation called the Keep Our Care Act, which was made it into committee and was considered in committee, but didn't make it out of committee. And that Keep Our Care Act, as my understanding, it was primarily concerned about the issue of equity, financial charity care, and financial access. Then we got, by all the connections, we heard from a group. There's a group in Western, was started in near Kitsap. I want to say Bremerton, but I'm not, but they are called Secular Healthcare. Let's see, Save Secular Healthcare in Washington. And that might be a group you should know about. They have a really interesting newsletter that comes out very regularly. They also have, they do a good job of linking up to almost anybody in the state that's doing anything with healthcare. So if you want to know, whether it's Pro-Choice Washington or the ACLU or whoever it is, they will provide information on that. So we became a little more interested in that. We also heard from the ACLU. For me, it was interesting. They were the coordinating group behind Keep Our Care. And I didn't know that ACLU was that interested in healthcare, but they are. And they talked to us in the, and the lawyer at the ACLU that was working on it is a woman by the name of Leah Ruman. I forget whether it's Boomer. Anyway, she is she came to talk to us. And then we've also talked a little bit about Medicare, but we haven't done as much on them because we were getting ourselves interested. Then I'll wrap up by saying there was one issue that came up where a couple of us listened in. In South Snohomish, we have a hospital district, and the hospital district owns Swedish and leases, it's Swedish Edmonds, not all the Swedish, but Swedish Edmonds. And they are also affiliated with the Providence Hospital up in Linwood, up in Everett. And out of the blue, they came to this without any particular public notice that we were aware of. They came to a meeting of Verdant Healthcare, which runs the hospital district, and said, we want to move the maternal unit, birth unit, thank you, the birth unit to Everett. And we just went, wow. And then we got it. Somebody told me first thing on a Wednesday morning or something, Lisa, early in the morning, they said, there's the meeting today and it's on Zoom. And then I got a hold of Lisa, and both of us were able to get on there. And then I don't know as much about what we did with that, but I think the number of people on the Zoom call gave some backbone to the hospital district, who had a lease that allowed them to say, no, you won't do this, and we're going to file lawsuits if you do it. So we won't go into the details of that. Then we wound up also having the director or one of the commissioners come and speak to us and tell us about the role of hospital districts and such. So that's a lot of what we've been doing, is educating ourselves. And I think I sent you some information on Saturday is the League's action workshop, which no pressure whether you want to be on it or not, but it's free, it's on Zoom, and you may find it interesting. So anyway, with that, that's kind of where we are. And I think I personally, and I think most of us on the call are somewhat interested in the concept of constitutional amendment protecting reproductive rights. But the League probably will not be an initiator of that. We will probably write letters. I'm waiting until this thing on Saturday to see what they're saying about it. But the League will definitely be supportive of a national policy of that. And then just recently, I received some information that there's a move afoot with the League to try and do a study of secular versus non-secular healthcare. So we'll see how that plays out. So
with the state league?
Pardon?
Is that the state league that might initiate a study?
Yes, the individual leagues. I don't, boy, I'm trying to remember. If you're doing an individual study, if a league is doing an individual study, it's usually for an individual issue that only affects the area that league covers. If it's more of a statewide issue, then it's a state, then it would be a state thing like the constitutional amendment. If it's a national issue, then it would be a national study. So, and the studies take usually a year or two to do. They're pretty comprehensive. So anyway, so I'll let the rest of the committee chime in a little bit. Who would like to speak next? How about you, Deb?
Sure. We're covering general health issues, and one of the things, I mean, if we just want to talk about the things that are on our mind, one of mine is the Snohomish Health District. You can't see that, but I noticed this today. We can stop the pandemic, but all they're pushing, and it's been bugging me for months, all they're pushing for we can stop the pandemic is vaccination. And there continues to be no mention of masking or increasing ventilation, which there was a recent article, I'm pretty sure it was Seattle Times, saying we may need to return to masking with this triple-demic because the hospitalization rates are so high that they're causing hospitals to be significantly overcrowded. One of them Children's went to code, whatever, where they had to start diverting emergency cases because they were so full. So my question is, why aren't we returning to masking? Why aren't we pushing the masking? Worked for 2 years. We got rid of one strain of influenza B, because it wasn't being spread because everyone was masking. And now we have this record influenza season. So we know what works to stop it, and they're not saying anything. So that's my soapbox.
Okay, Lisa, how about you?
Oh, well, of course, I have several soapboxes, but let me just give you a little bit of information about myself. So I am the chair of the Emergency Cold Weather Shelter for South Snohomish County. So the COVID and Narcan issues have been really big for us recently. Our shelter requires everyone to be masked. We're over the course of the pandemic, we never did have an outbreak of COVID at our shelter, and we think that's because we've got a doctor on our board who is really, drills this home every time and makes sure that we are kind of going to the nth degree in terms of this. And she says that she's expecting the numbers to go up, and that Snohomish County is. So we're interested in that. Of course, all of our staff is trained in Narcan, and many of our volunteers are, because we're concerned about the opioid epidemic, and we think that we're having more people who are because of the strength that this is not all stuff that we've talked about in this committee. So I'm kind of doing this for you, Joy, just so you have an idea of the kind of things that are rattling around. That because of the strength of the opioids, and particularly the fentanyl, people are not able to make it through the night as well without having a hit. So almost all of the shelters will not allow, I mean, they're drug-free zones, right? So that is becoming an issue. You're finding a lot more people who either will not come in from the cold because they can't make it through the night, or who will try and get around the or you go find them that someone has been in the bathroom and they've been using it. So that's an issue. I mean, we are very clear with our guests and with the police when they bring people in and everything, that's not that we can't allow that for the safety of others and for the safety of people who are at the shelter and the people who use that. And I'm sorry, my voice is kind of weird today too, because I've had some illness. So I usually sound more like a normal person. So that's two things. I did want to mention in terms of the reproductive choice that the league has taken a pretty strong stand on this at a national level. And two of the council members in Edmonds put forward a resolution immediately after Dobbs, and we, the league, several league members showed up to read the national statement about that, and Edmonds did pass a resolution, and that was I think this is a really interesting thing, and which you may not, there was a lot of concern that there were people on that council who did not want to support it and who did not want to bring up something that divisive. And yet in the end, although one member of the council was gone, it was a unanimous vote in support of that. And I think that speaks to the kind of the understanding of how supportive the community at large is about that. And then, and I think one of the other things that has not been talked about, I'm just blathering on here. So
No, go ahead.
to wave your hands and say, okay, enough, Lisa, you're taking up too much airspace at any point in time. Anyone. One of the things that has not been talked about is how I think that the creation of the hospital districts was because the market was not working. It was not providing hospital services to areas like Snohomish County as it was developing. And I'm really proud of the hospital district down here that they had clearly rejected Providence's offer to provide hospital services at their hospital when they were moving from a hospital district to this kind of thing where they now just contracted. They specifically did not pick Providence because it was not secular healthcare. It was religious healthcare, and that provides some limitations. And I think that that's a really important point. And I think that if there were some more stories about the through line on that the market's not working, how we know it's just so obvious in terms of people getting care, in terms of equitable care, in terms of the healthcare for the whole community. Anyway, that's just my 2 cents on putting a story together and educating people. And then on Medicare, I really feel like there has been it's very, very hard to get to to get really good information. And that's because my personal opinion, not the league's opinion, is that's because the insurance committee, the insurance companies are pushing the agenda. And I think it's pretty clear that they're at this point trying to dismantle Medicare, which is a disservice to everyone. And I could probably blather on, but I'll give my, thank you very much.
Can I ask you a question? Lisa, when you say it's hard to get good information about Medicare, what specifically are you referring to?
Well, you can get information about the plans, right?
Mhm.
But in terms of Medicare Advantage being a private insurance thing that is pulling money away from the basic Medicare, that information is harder to find. And in terms of individuals making a choice, understanding that they will tell you, and I think one of the places that people really need to dig on this, or a reporter could do some digging on this, is the SHEPA program presents it as if you can move back and forth between traditional Medicare and Medicare Advantage, and that is proving less and less to be the truth. And that needs to be clearly available to people, because you cannot move freely back and forth. And that's becoming really clear. So I think that's a real disservice to the community.
Right. I think Lisa's right on that. Really, really right on that. When it was interesting at a recent league board meeting, I brought that up, and one of the board members said, "Well, Edmonds Waterfront Center, which is the senior center, it is a wonderful facility with tremendous number of services. All they have to do is go down there and listen to the Medicare. They have volunteer Medicare advisors." And I haven't gone and listened to them. But I suspect they don't understand that issue, because the issues that Lisa mentioned is quite complicated, and we haven't even educated ourselves real well on it, but it has something to do with pre-existing conditions. You know, if you move from one healthcare plan to another, that's regardless of anything. But if, for example, I have cochlear implants, and if I was in the middle of cochlear implant surgery when the move was made, the original insurance company would have some involvement in how that is funded. So you might, if I was moving to a different insurance company, to a Medicare, traditional Medicare, whatever, I might want to might be doing so because I wanted a different surgeon. Well, suddenly I could be still constrained by the fact that the original healthcare, however I was insured under my original healthcare, still had a responsibility financially, and still could. That's my understanding now. I'm not fully educated, and that's something I'm hoping after the first of the year we will be finding out more. And if one of the things I wanted to offer, I will add you to the distribution of our agendas, which was you don't have to come to anything, but if there's an agenda that comes out that you're interested in, just join us. So, we have one, I think we'll turn, Marie, would you like to chime in with?
I actually don't. I'm fully supportive of every topic that has been brought up and discussed. And I feel like I'm still in the very much learning phase of educating myself on these topics, but 100% supportive of every topic that's been discussed.
Okay, Denise, I don't see your picture, but I think you're still here. So do you have anything you'd like to add?
Video.
Hi, there
Hello.
you are. How nice to see you.
Well, Joy, I'm brand new to this committee, so I'm feeling, shy, and just starting to educate myself on some of these topics that I didn't know about before. And I really appreciate the article you wrote about the Everett Clinic and Regents, their dispute, because I am an Everett Clinic user and my insurance is Regents, so it affects me very, very much. And thinking about that and how I may decide to change my providers, this committee has brought me to my attention that I should pay attention to who owns my provider, and if it's secular or not. And I don't know, that's just something I'm thinking about, and it's timely because I bet there's a lot of us that are thinking about who will I go to if Regents doesn't cover the Everett Clinic. So that's what I'm educating myself on right now.
Yeah. One of the things that surprised me when I moved up here, because certainly Western Washington is, as far as I could tell, for one thing, was touted as being a great place for people that are retired to move to, because there's a lot of things available for retired people. And by the way, I moved up here because my daughter lives in Anchorage, Alaska, and I don't want to live in Alaska. Anyway, that's but I was surprised when I actually moved up here at the dearth of healthcare options in Washington. It surprised the heck out of me, because I lived in a city called Claremont, which is kind of in northeast LA County, and it's part of, right on the edge, or part of the Inland Empire, which isn't a particularly wealthy part of California. But I could get to probably 4 different hospitals within a 15-minute drive of my house. The emergency rooms, they probably took you to one particular hospital, but there were a number of hospitals, lots of medical facilities. I mean, it just surprised me, because Edmonds, where I live, is very similar to Claremont, the city I lived in terms of all the demographics you could ask for are very, very similar, the way the city is structured. And yet it appeared to me that the medical care options that were available to me in Claremont were a lot more diverse than what I have here. So that's one thing that surprises me, that may be interested in that. Fits in a lot of things. The other thing that came up that I think is important for all of us to recognize is, because I'm looking at how we deal with women's rights and women's health care, and I have been not surprised, but in getting involved with some younger women in terms of reproductive health care, and it made me very aware about the whole bodily autonomy issue that I really hadn't paid that much attention to, in terms of reproductive rights. I was more of a pragmatist. If someone needs to have healthcare, reproductive healthcare, let's get it for them. But for younger women, that is hands down huge. And that, I think it's something for all of us to consider, because if you think about what was happening with removing the maternity benefits, let's forget the secular issue, non-secular issue. You live in Edmonds and suddenly you're in labor, and whoever's getting you to the hospital, yourself, your husband, your whoever, you have to drive to Everett to have your baby. Well, look at, if it happens to be at 4:30 at night, have you ever gotten on Highway 5? Or, they would rival any city in the United States for terrible. So the access of, and then I listened to some of the non-secular healthcare people, they told us all, well, make sure if they pick you up, if the emergency, the EMTs come to you, make sure they take you to a secular healthcare hospital. So you're sitting there, your husband's just had a stroke, and you're arguing with the EMTs of where they're going to take you in. For my case, Swedish is 10 minutes away. You're not going to do that. So I think I don't know how we investigate that. I don't know how we influence that, but it's just amazing to me. And I haven't looked at healthcare in, say, Yakima or, Wenatchee, or even Spokane, which has got to be a whole, I don't know. I don't think I'm off base on that. So I think a lot of this is just continuing to educate ourselves and trying to have a voice where we can, like we did in terms of talking to Edmonds, and how you phrase these issues. Because I don't know. I told my husband last night, I'm tired of being angry all the time about how I think women are being treated. But every time I think I've moved on into a new plane where I'm mellowed out about it, something else happens somewhere, just like, sheesh. So anyway, that's my soapbox, sorry. But a lot of this committee is about educating ourselves. And certainly after we find out what but my understanding that the league's issues, and they do have at the state level what they call a healthcare issue chairs and a healthcare affinity group where the local leagues get together, and they expect to be dealing with whatever COCA, which is the Keep Our Care Act, won't be COCA anymore. It'll be something else, but they expect that to be reintroduced. They expect something on reproductive health care. Behavioral health access is huge. Workforce. That's one of the things that the league has been talking about at the state level, is the whole issue of healthcare workers and how many people there are, and how we support the people that are already in the healthcare system, but how do we improve the method for getting them? Like I saw something recently where they were talking about nurses using simulators to give nurses part of nursing training, a bigger part of nursing training, so that you don't have to spend so many hours actually in a hospital or clinic setting getting the things. And I was thinking, my husband was in the Navy and he flew on he wasn't a pilot, but he flew on P3 airlines or P3 Orion, which are the ones that hunt, the hunt for submarines. Almost all their training was in a simulator. So if we can use a simulator to allow people to learn how to drop bombs, I think we can use a simulator to help augment nursing training. But that's kind of off. But that's the whole workforce issue is something that is a big deal, not just for behavioral health, but there obviously are holes of behavioral health. So that's kind of where I think we're happening. Okay, Lisa.
Oh, yeah, that kind of brings up something else that I wanted to mention. I think that related to workforce, I believe, and I've been really busy lately because of the cold weather, so I may have missed things, but it seems to me like the Herald has had 3 editorials lately from hospitals or hospital districts or whatever, and I don't think I've seen anything from labor. And I think that they need to be asked to write a guest editorial about this, because their voice in terms of, I think this played into this, what happened in South County between Providence and Swedish. I think there are many factors, but I think labor is one of them. And because management was, Providence was clearly using, the shortage of labor as a reason for why they were doing this. And I think labor needs to be brought into that. And that when we have some strong nurses unions in this state that should be listened to.
Yeah. Well, I know in California, one of the most powerful unions in California, which is a union state, is the nurses. And I don't remember the name of their union, but they are one of the most influential labor unions in California, and we seem to Washington and California seem to track together on a lot of stuff. But so
can I ask,
okay.
Tessa, you're recording this, is this just for sharing with the other committee members?
I can share it with you.
Oh no, I just mean it's not shared more broadly.
Yeah, I don't usually I really haven't recorded most of them, but I had someone who couldn't be on the call today want me to record it. So now I don't know. I know how to turn recording on. That's about it. I have to.
I'll tell you at the end, make sure you pay attention. It's going to pause and start converting it, and then you have to save it. So don't click out too fast. I've made that mistake before. Well, I wanted to ask though, so it's definitely of interest. Most of the things you talked about are of interest to me and to other folks at the Herald. On the religious versus secular access to care and issues in the county, that is an issue I used to track. And I feel like at the hospital level, there have definitely been stories, and this is, it might have been a while. And, Providence as a Catholic system, follows those ethical and religious directives that can really affect, not just reproductive access, but transgender care and end-of-life care. However, some of those things really are more about clinic care, and that it's harder information. Clinics are harder on a data side to access in many ways, right? The number of clinics, the number of providers, the number of visits. and what kind of care happens there. Whereas the hospital data, with $50 or so, I can get in there and see a lot of what's happening. So all of that to say is I would be very interested in hearing from you or other members of the league. If you come across stories of people in Snohomish who have tried and faced barriers to accessing care at clinics, and then this would be Providence clinics, I think would be the only ones in the county that are religiously affiliated. And if they've faced barriers to care in those settings, and you know, those are the 3 buckets that I'm aware of. There could be something else. So that's always helpful to have, right? That narrative, and then a sense of, well, from there, could I find out more? Is there a data source or something where I could find that actually, you know, a certain service is never being provided? And then I can also interview more intelligently representatives of the different providers about what is happening or not happening in those clinics.
So I'm under the impression that Providence has also bought out some practices.
Yeah, probably.
Like, and I think that's and my understanding is that the doctors who sign the ERD, the thing about the ERDs at Providence then cannot provide those services at those practices.
Right.
And I don't think that that's at all clear either, where those practices are owned.
Mm.
And that should be publicly available somewhere. I don't know where.
Yeah.
Yeah, I think a lot of the information is hard to find because a lot of it is especially end of life care, you know, where someone, because you have a stressed out, you have a person that's dying, obviously, and then you have their family members or significant others, whoever is there to support them, who are in a very precarious situation, very stressful situation, and they're running up against them. And, you know, by the time you get it resolved or not resolved, I mean, if the person is dying, there's going to be certain resolution with their death. Now, whether the death is death with dignity or death by, you know, healthcare torture or something. But when it's finished, it's like, I'm sure everybody just says it has a sigh of relief and goes away. So but I think if we hear stuff, and that's up to all of you, if you hear, you know, if we get stories, because I think all of us have probably heard stories, and it's just a matter of seeing if those stories are something that we could send on to you. And I think, because I'm afraid now, I don't know if you, Deb, or anybody like that is doing some of this, but again, it's a very, it's one thing if you go into a hospital and they say, I want an abortion, and they say, no, I don't, I'm not going to give it to you. And you can go run out and tell somebody they wouldn't give it to me. But a lot of it, I mean, a couple of the stories I've heard are absolutely horrific. But then you know, it's hard to know how to grab onto those and get the person to happen. But we can, you know, I'm willing to, if I get stuff, and I think anybody here is, if we get ideas, we can share it with you. But to me, I think if anybody's doing research on it, it's probably somebody affiliated with University of Washington. Because we've heard the same thing. The data is not easy to come by. You know, we're not going to find out people in Medicare who got denied, you know, couldn't leave a Medicare Advantage plan because of the whatever issues there are with pre-existing conditions. Almost everybody over 65 has a pre-existing condition.
I do share of those of us under 65 also have pre-existing.
Well, that's true too.
Yeah.
So I have a friend who works with, I believe it's End of Life Washington, volunteers. And so she's actually assists with death with dignity issues. And she has told me stories about people who couldn't obtain the medicines in time for them to be able to swallow the pills and the challenges that creates. So if you have interest in talking to her, I could see if I could connect her up.
I definitely do. Was that, and those barriers they faced weren't necessarily particular to religious healthcare, but just
just to
Got
being able to access end of life care.
Yeah.
I don't know about religious, but I'm confident she has stories. But the other issue that we're not talking, well, it's a rare issue, but I have Medicare, and my husband is looking to retire. But in order for me to get a Medicare supplement plan, I'd have to go with Medicare Advantage. I have taken the class through the Edmonds Waterfront Center. If I get the Medicare supplement plan, then I cannot go to the traditional, if I go to the Medicare Advantage, I can't get onto the traditional Medicare supplement till I'm 65, and then I'd have to undergo underwriting, and then there's no way I'd pass underwriting. So
that's where they wanted. Thank you.
Yeah. So my husband either can't retire, and I'm 7 years younger than him, and he's turning 65 in March. So either he can't retire, or to stay on the retiree Medigap plan to keep me on his company Medigap plan is going to cost us $550 a month. So it's cost prohibitive. So it's actually preventing him from being able to retire. So it's not just an issue of, people wanting to switch. It's a real life issue of not having access, because the Medicare Advantage is not something I would want to be on long term.
Wow. Well, I know that my husband is retired from the Navy, so we get TRICARE as our supplement plan, but we got a letter recently during the Medicare enrollment saying, if you have TRICARE, you don't have to sign up for Medigap or a prescription health care, because TRICARE covers that. So obviously retired military have been signing up for these plans. But what happens if you're retired military and you sign up for the plans, sometimes what would happen then is that plan you sign up for is primary, and your TRICARE, which TRICARE for life for retired military is absolutely phenomenally fantastic. I didn't really care about whether Dan was in the reserves for all those years, but now I'm really glad he was. but the fact of the matter is, the only reason they sent out that letter, we've never gotten that letter before, and he's been retired for 3 years. So obviously Medicare Advantage plans and Medigap plans are letting these poor retired military people sign up for plans they don't need. Which is, and I understand. A friend of mine said her husband's older than she is, and she said, well, he's probably going to die before she does. She's a lot older, and she may still not be eligible for Medicare, and may be completely kicked off whatever health insurance she gets. So I don't know all the details about that, but I'm going, oh crap, jeez. So anyway, that's one of the issues, is people understanding Medicare. People that can access Medicare are certainly better off than people that don't have any insurance at all. But it's not as wonderful and easy as people think. So I don't know. What other issues that we haven't talked about do you think might come up as something, in case because we're kind of, as you can imagine, we're kind of eclectic, and we kind of go with what one of us has interest in when we can find a speaker.
Excuse me.
Sorry for making you talk.
I think I can talk a little bit. I feel like you've covered a lot of what is definitely on my near-term interest. The opioid crisis. I think behavioral health access, and just like the different kinds of treatment and care that people do or don't have access to in the county. I think the overall workforce shortage is an issue. I would like to dive into network adequacy, which is that wonky term for does a health insurance plan have enough options for people? But I need to catch up on what's been done at the state level. So that's like state level legislation, but I think it's really complicated, And it's really important given what I've heard from people in Snohomish about not being able to find providers or not being able to find them for months, all kinds of providers. And this was before Regents and Optum, might not sign a deal. So I'm curious and diving into that as a kind of wonky policy and data piece and people's experience and like what are the solutions coming down, right? I know Kaiser's building something, but right, just this very clear sense that all kinds of healthcare providers, the growth in providers in the county has not kept up with the growth in population. So I wanted to add that I think I'm very interested though in still understanding what is happening at the county and local level with policy. Like what are they going to do with the opioid settlement money? What do folks want them to do? The county did all these listening sessions for the ARPA funds and found that behavioral health was a huge priority for people, and they've allocated money and they've put out some RFPs now, I think, or some grant applications. So I really want to track that, but I'm sure I'm barely into this, that if there are things happening with city and county council level that you think are important, I would love to hear about them. And I could say vice versa as I start to track more of the weekly and monthly happenings. But I'm very interested in the ARPA money and the opioid settlement money, and kind of the long-term capacity building that could lead to.
Okay. Well, one of the issues I know in my working life, I was responsible for the administrative end of the court system in San Bernardino County, California, which is a big deal. And one of the issues we always had is propping up here and becoming worse. And that's psychiatric and mental health providers for juveniles. Even when you didn't have the shortage that we have now, being a teenager is kind of crazy anyway. That's what a lot of us that were raised teenagers kind of feel when, it's a time of them. And there's a lot of providers, even when in a place where there's plenty of them, who don't want anything to do with teenagers. And yet you have a population. So I think it's coming because of COVID and school system and fentanyl and everything. I think it's coming to a head. And somehow parents that have a kid that has encountered with juvenile court, there's just not a lot to help them, and they don't know what to do. They have a kid who may be on the road to being another Jeffrey Dahmer, or just may have gotten a traffic ticket and one slap of the hands is, and you don't know, and I think that's a looming crisis that we are probably not going to do a whole hell of a lot with unless we start delving into behavioral health. But I think it's an area where we have to care about those kids, and that we have to give the parents more support than we give them now. Because I know I was an administrator and I had so many friends that got a hold of me and said, what do I do now? And all I could do was try to tell them where to find a lawyer. And that may help the kid stay out of juvenile hall, but that's not the answer. But anyway, that's one issue that I'm not sure how to get a handle on, but a special subset of behavioral health that is going to be completely, going to be really difficult to deal with.
Yeah. So, and I used to work on mental health. I used to run the state office of NAMI, and then the county office. But my information is all pre-COVID, and of course it was always a tough time at that point. And what we were finding was that in terms of network adequacy, that people, there were several cases of insurance companies listing providers in the behavioral health thing who weren't actually their providers. I mean, that kind of crap just makes you furious. But I haven't kept up on that recently, but I know that through this pandemic, I know a lot of people who had really good healthcare who could not find a provider. And that is both for adults and youngsters. Yeah.
Well, when my husband and I moved up here, which would have been 3 years ago, and we have outstanding healthcare and pretty good financial resources. So none of that was an issue. And I kept trying to understand how to find, it was a while. And I finally gave up on trying to find somebody that was handled geriatric medicine. We just wanted a doctor. Then we got one and she quit. And my husband gets VA benefits. He had to be a doctor and he quit. It's like we had this first year just trying to find doctors. And I think what winds up happening is people access specialty care because they can find a specialty doctor. Well, that's the most expensive and not necessarily the most comprehensive way for someone to get health care. But that's, you wind up going to an allergist for an earache. So I think that's an issue for healthcare across the board. And that's, I don't know if it's a workforce issue, an insurance issue, whatever, but it's probably all of that. So I think we can just keep you apprised. And if feel free to reach out to me if you think there's something specific questions you might have that we could look into. I will, once I know what the healthcare agenda is, a little bit more about what the league's healthcare agenda is going to be, I'll send that information on to you and you can just ask me. I do know that I know that pro-choice Washington, should you get interested in what they're up to, they're having their lobby day in January. And I just said I participate. I don't know what that means, and it doesn't mean I haven't been that. I've gone to a couple of their meetings, but I haven't been real active. So
That all sounds great. Thank you.
Okay. Any?
Well, I don't know whether Tressa contacted you, Joy, or you contacted us, but it was very therapeutic to talk to you.
Oh, good. Can't find a licensed therapist, but a journalist.
That's one thing. I think all of us were really happy that the Herald decided to have a reporter that did that. So I think you can tell your boss that we are 100% supportive. And if you ever need us to write a letter and say, yes, we like what, we're happy to just let me know who. But I think the articles that I saw were good. They're important stuff. So, because we all need to think about healthcare before we actually need to go to the emergency room. So anybody else? I think we're close to 1 o'clock, and I'm sure Joy would like to get some warm tea or something for her throat. So, okay, with that, I guess we'll sign off, and I'll once I figure out where the recording goes with this, I'll let everybody know. And I'll probably wait till after the meeting on the meeting on Saturday. And for those of you on the committee, I have a couple. One thing is that if you want to go to the league's action workshop and you didn't get something for me, let me know. The other thing, even though the action workshop says it's from 9:30 to 3. Last year, I went at the beginning, found out when the healthcare breakout was and stayed for that and didn't stay for the whole thing. So you don't have to commit that. The other thing that we received, as I mentioned at the beginning, there's some interest in having a study of secular, or what they didn't call it secular, they called it healthcare access. Let's see, healthcare laws versus actual access. So if any of you, I haven't decided, I'm still kind of torn about that whole issue of the study, but if any of you are interested in at least learning more about that or what the commitment would be, let me know, because I'm sometime after the league board meeting on Monday, I'm going to be contacting this woman and try to find out what she's talking, how much time commitment and what little more detail about what that is. So with that, happy holiday, everyone. And Joy, thank you so much for joining us.
Thank you for having me.